So our third speaker is Dr. Mitchell Brooks. He's an orthopedic surgeon and formerly family practitioner with extensive experience in both conservative and surgical procedures involving orthopedic disorders. He's been a visiting lecturer in sports medicine and orthopedic surgery at the University of Cardiff in Wales, and helped develop one of the first privately operated orthopedic sports medicine surgical centers. He's authored books, he appears regularly on TV, and he was also headed a design team for a 36,000 square foot Jeep hospital using physician, nursing, patient, and payer-focused groups. This right-sized hospital is capable of performing 90% of product lines of a standard 200-plus bed community hospitals at 30% of fixed costs. So I'd like to introduce Dr. Mitchell Brooks.
I'm going to be a little less formal, and since the crowd's thinned out a bit, if you want to come on down, you can. And I'm going to make the camera guy work. So, what you've heard so far from the two speakers is tactical information in controlling healthcare costs. And if you listen very carefully to what they both said, there was a tremendous amount of overlay. And what Tom Hubbard said about Dr. Burrell's talk is absolutely on target. Her talk contained all the issues that we're going to face in healthcare around the homeless community. So there are principles that you heard in these two talks that are tactical. That is to say, how are we going to do what we need to do? I'm going to take a different approach. I'm going to ask you to think strategically, as we say in Texas. And I'm going to ask you to look at the whole picture and see how you fit into what the future will hold. Because this talk is about you. You guys are going to control the costs. We're not going to, because you're where the rubber meets the road. So, I always like to ask, what if? What if we could do this? What if we could do that? And some people, if I can do this right. All right. I always think of healthcare policy in the United States as Gene Wilder and in this picture, young Frankenstein. We don't know what we're really creating. We have no direction. And yet we're policy driven, but we're not practically driven. Dr. Burrell gave you an outstanding example of practical. Next. For me, in the clinical environment, seeing patients and looking at things from the ground up, I think that there are several issues that we are facing today. First is that most people feel health care is a right and not a responsibility, and that affects their behavior. And you notice that Mr. Hubbard talked about success with appropriate use of drugs. And that's a critical success factor, appropriate. Dr. Burrell's appropriateness went to delivering care directly to the individual. These are all ways to do what we need to do. The consumer, though, has no skin in the game. If something is not costing you anything, are you going to be apt to follow the rules or not? So for instance, in my practice, people want an MRI if they have back pain. They don't need an MRI. So generally speaking, what happens is, I say, well, I don't really think you need MRI because this is what you have and I'm pretty sure of it. And they say, yeah, but I want an MRI. I said, well, okay. And then they ask me, well, does my insurance cover it? And I say, I don't know. Generally speaking, if the insurance doesn't cover it, they're not going to get the MRI. And that's human behavior. And we need to capitalize on that to control costs from the demand side. And we're not doing that. We're controlling our costs from the supply side. And that doesn't work. And if you think it works, I would suggest you go to Canada and Great Britain, have a look around, then come back and talk to me about it. It doesn't work. Political solutions are what we have from Washington. You heard a perfect example of it from Mr. Hubbard. it took the Congressional Budget Office how long to do something and how much money was wasted when something was there, statistically significant in front of them, and yet they were politically driven. Political solutions are not going to work here because politicians don't want to be accountable. So they're not going to do anything to annoy the electorate. And the electorate has to be annoyed here. Otherwise, nothing is going to happen, nothing's going to change, and our costs are going to continue to rise as they are now. And last, I really do believe that we are only controlling the supply side. We need to control the demand side, and we're not going to be successful if we don't do so. And there's a great paper out of British Columbia, the Fraser Institute, which talked about the future of Canadian healthcare using a semi-modified American model to control the costs. So perhaps somewhere in the middle between Canada and the United States is our solution. I don't know. Anyhow, next slide. People ask me what the future holds. I have no idea. I don't know. Do you? Anybody know where the future, what's going to happen tomorrow and next day? You've heard principles or you've heard tactical issues here, but I don't know. So my challenge to you today is create a blank canvas for yourselves, because anything you want to do is possible. Anything. But when you create that blank canvas, you have to be aware of what's going on. And you can't know what's going on if you're looking at things from the ground up. You got to look at things from 100,000 feet and recognize the principles under which you must function. If you get away from the principles, things are going to go awry. It's great to innovate the manner in which you want to achieve those principles, and Dr. Burrell, again, has shown you what happens when you can do that. The most effective slide that she put up there, to me anyhow, was the whole idea of process reengineering. And you saw that with all the sticky notes. And that's an exercise I do all the time in all the consulting I do. We've covered walls with 3x5 cards. You have to control the process. Outcomes are 100% determined by process. Period. End of discussion. Next. By the way, anybody know, go back, Frank. Anybody know what that is? Who said that? That's correct. It's the Grand Canyon. Next. So to me, I look at where the money is spent. Willie Sutton robbed banks. He was from this area. They asked him why he robbed banks. He said, that's where the money is. Pretty simple idea. So where are we spending money? Next. If we look at a breakdown of costs, the hospital represents approximately 33% of the $2.7 trillion and growing budget for healthcare. Administrative costs, which is the idea of processing claims before payment, is 9%. And by 2018, it's going to be $315 billion just to process a claim. And physician costs are 19% next. Pharmacy costs are 9%. It's about $250 billion, okay? And I'm going to talk about how you can address those costs in your lives using some ideas. Next. So again, the whole idea of if we look at things from where we are, and we start from where we are, all we're going to do is paint a picture of ourselves today. You can't start from where you are. You must start from where you want to go. You must start at the end and work backwards. Otherwise, you're just going to be painting yourself. Next. So, to me, what happens if you create your own process and you set the expenses? Well, Dr. Burrell showed you what happens when you create your own process. That was perfect. Thank you very much. It was a great lead-in. And it works. You have to re-engineer processes wherever you work. And that's going to be difficult to do because there's going to be resistance to change. There's always resistance to change, always. But you have to be a change agent, buzzword, by the way, change agent, okay? And that's important. Next. I always think about having your own insurance product. Now, the exchanges are a first approach to that, but I'm not so sure they're going to be effective Firstly, the computers don't talk to each other. Secondly, there's a whole layer of bureaucracy involved. And thirdly, nobody really understands how they work. Next. And expenses from existing conditions alone are out of control. Mr. Hubbard showed you that. Dr. Burrell showed you that. I don't need to beat that horse. It's dead. If we can control obesity first, diabetes, and heart disease, we're in control of things. And in order to do that, you have to engage people directly, and there has to be a cost to them if they don't comply. That latter part is my piece. Next. We want to have a single-payer system here. I don't believe it's going to work, but I believe a single payment system will work. Why? Because in Ontario, they can process a claim that we process for $1 for a quarter. Now remember that 9% was, or 16% was before payment of the insurance. And if you extrapolate that out, it's a lot of money. Next. This is a graph of what happens when healthcare expenses are a proportion of the gross national product. And you can see when people have skin in the game, there is a definitive drop in the healthcare expenses. Now, some of that is due to the economy, but that graph really tells you quite a bit. Next. Now, I happen to be interested in what we call a hospital, and what I call a place where you do stuff to get people better, because that's all it is. It's a place where you do stuff to get people better. If you call it a hospital, what image comes to your mind? I mean, to me, it's driving up Storrow Drive, right? And you know, you look to your right and there's a hospital. Well, that's a very special kind of hospital. It's not a hospital that can give care to 90% of what we want. Certainly not at an expense that we can afford or tolerate. So what is a hospital? It's a place where you provide care to sick people that cannot be cared for at home. What has changed? What's changed is we don't really need to have people in hospitals anymore. You saw the graph of intravenous use. You saw Dr. Burrell talking about direct intervention, cutting down hospital admissions. That's just part of it. What happens when you do the stuff? You can do the stuff in a small facility. You can do the stuff in 36,000 square feet, which is really tight, but 65,000 square feet at $500 a square foot gets you between 20 and 30% of the fixed costs. Now that's a substantial amount of money. You're talking about hundreds of billions of dollars. And we do things today arthroscopically, we do things today minimally invasively, right? People go home. When I started doing total hips, I kept people in the hospital for 4 days. They go home after 1 day, and there's really no reason to keep them. Why are we keeping them there? Our ability to take care of people in a non-hospital setting has grown exponentially, and I'll show you in a minute how the iPhone or a smartphone is going to be your healthcare partner in the future. Actually, now. Next. So these are components of healthcare spending per patient population. The blue is the inpatient care, the green is the outpatient care, and the orange is for pharmaceuticals and other non-durables. So you can see, yes, it's all going up, but look at the amount of outpatient surgical procedures. And yet we still have the same number of hospitals that occupy real estate. Next. So I've made that point before. The hospital on the bottom was 1 million square feet. This is a book, make up your mind. This is actually a book by Eric Topol, and it's called The Creative Destruction of Medicine. And you'll read a lot of the things in that book that you've heard today, because what you've heard today from the first two speakers, and hopefully from me, is what is called convergent evolution. What is convergent evolution? Ideas are a dime a dozen, but there are certain ideas, irrespective from where they come, that stick. And some person might have an idea in Reno, Nevada, some person might have an idea in Paris, France, wherever around the world. And eventually there's a consensus that's built. And they come together and converge into the tactical principles that you heard today. Because their two talks were essentially the same, if you listen carefully. Next. I talked about apps. These are apps now that are available on your iPhone. Now, you can do an echocardiogram in the office, all right? It used to be that you had to go to the hospital, wait 2 hours, then have the echocardiogram, and you lost a half a day of work and productivity. You lost a half a day of your ability to look after your family and look after yourselves. That can be done now in the office with a little chip fixed to your chest and with your iPhone. And it doesn't even have to be done in the doctor's office. You can do it at home, or you can do it in a Minute Clinic. And the data and the pictures and the echocardiogram get electronically transferred to the appropriate place. The savings just from that one procedure alone, I calculated out to be $8 billion in 1 year. Now, when compared to 3.7 trillion or 2.7 trillion, it's a drop in the bucket. But think about all the procedures now that we're going to do, and think about what you can do if you have your blood sugar taken at home. Think about what you can do when, as pharmacists, you can interact on an iPhone with somebody. Because what Mr. Hubbard introduced to you is how you're going to behave in the future, and how you take that information and what you do with it and innovate it, that's on you. That's on you. What is a pharmacy? What will the pharmacy look like in the future? Next. Picture on the top is an ICU. Picture on the bottom is something you wear on your wrist that gives you the exact same information that you see in the picture on the top. So is it necessary to have someone in the ICU once they're stabilized? No. Do people get better in hospitals? Anybody know the answer to that? No. You want to get people out of the hospitals because they will get an infection. So here's an innovation that's really quite incredible. And now people are developing implantable chips that will read certain parameters for disease processes and let people know ahead of time what's going on. We have genetic mapping, and on and on and on and on, and I don't have to go through it. Those all can be utilized with these principles that you've heard and the principles I've given you in the overview to cut costs. Next. So what if so what if in the future the community pharmacy becomes the center of healthcare? You guys are not using all your education. Many of you will go into the business world and you'll spend your lives getting a wry neck with a phone like this and writing a prescription out and doing 2 or 3 things at one time. You're not educated to do that. The amount of money you're spending on your education to have that kind of return makes no sense. You're not being properly utilized in the healthcare environment. Now, I didn't know what Mr. Hubbard was going to talk about, and yet we're talking about the same thing. That's convergent evolution. So how can you better utilize your services? Next. Well, let me give you just one fact and let you take that and think about the small hospital and think about what you heard from Mr. Hubbard. The total number of hospitals in the United States that belong to the American Hospital Association that are registered is the number below. The number above is the total number of retail facilities of just CVS and Walgreens. Now think about that. Think about the real estate in the community and what you heard about the direct delivery of care and what you've heard about small hospitals and what you've heard about convergent evolution, and think about what you would do for yourselves if you had a blank canvas. Where do you want to go in the future? Anything you want is true. These are facts. I'm not telling you what to do. I'm telling you to use your brains. Because the cost savings are really going to come from you as a pharmacist and as a consumer. Next. So basically, I'll end with something that one of my mentors gave me a long time ago, and it's a really great way to talk about thinking out of the box. Thus, the task is not to think what nobody yet has thought, but to think what nobody yet has thought about that which everybody sees. And you've heard examples of that today. So, what can you do with information technology? What can you do with your full educations? What can you do with 15,000 facilities as opposed to 5,000? What can you do about those circumstances and those facts given what you've heard from the other two people about direct care? What about patient involvement, community involvement? What is the role of the pharmacist? And that is up to you. Only you can decide what you want to do. Nobody else can tell you what to do. And in the end, the ball is in your court, and the ability to control healthcare costs goes to you both professionally and personally. Thank you.